Hello, friends, welcome back. Earlier this month, I posted a lecture on the pathophysiology and subtypes of the Hepato-Renal syndrome about the net filtration pressure in the kidneys and the activation of the antidiuretic hormone renin-angiotensin-aldosterone system and the adrenergic system. Today, my objective is to talk about the pharmacological management of the Hepato-Renal syndrome patients. Now, I want to start from where we left off earlier. This is the slide from the previous lecture I posted on March 11, 2023. We were basically talking about the results of the compensatory mechanism. The idea is to retain sodium, water, and also to increase the systemic vascular resistance. This is all happening to maintain the arterial circulatory integrity, or at least it's a good attempt by the body until something really happens bad to destabilize this mechanism. Then we start seeing the pressure, the filtration pressure in the kidney drops, the kidney starts suffering. There could be any reason, there could be progression of liver disease, or the systemic vascular resistance is so low that none of these compensatory mechanisms matter anymore. There could be some triggering events like presence of infection or presence of spontaneous bacterial peritonitis, or could be severe bleeding. The basic idea is when you are no longer able to maintain the circulation integrity, the urine output starts going down significantly, kidneys start failing. Depending upon how fast the damage to the kidney occur, the HRS divided in type 1 and type 2. Type 1 is where we the damage occurs very fast, is considered more acute, and severe damage to kidney can occur very quickly. Usually, if the serum creatinine become double or become greater than 2.5 milligram per deciliter within 2 weeks of onset, and these patients have very high mortality rate. Unfortunately, 80 to 95% of them die within 30 days. With such a high mortality rate, how can we manage or treat these patients? Um, the treatment options, especially for type 1 HRS, unfortunately, there are not too many. We can try somehow if we can improve the liver function, try to recover the patient from alcoholic hepatitis or from acute hepatic failure. If the patient has decompensated hepatitis B, then treat those patients with antiviral agents. The best option is, of course, the liver transplant. In the meantime, while the patient is waiting for the liver transplant, we can use some pharmacological agents which can serve as a bridge to liver transplant. Now, once the diagnosis of the HRS-AKI is confirmed, then the prompt use of vasoconstrictors in combination with albumin is currently recommended by the expert panel to have higher chances of recovery. Among the different vasopressors or vasoconstrictors, we can use terlipressin, norepinephrine, midodrine, and octreotide. Terlipressin is a long-acting synthetic analog of vasopressin and has been used in other countries. It recently got approved by FDA in the United States. But why do we use vasopressor? The logic behind the using the vasoconstrictor is because the splanchnic arterial vasodilatation is the main reason behind HRS-AKI. So idea here is to constrict them back, constrict the splanchnic arteries by giving vasoconstrictors. So we give these agents to raise the mean arterial pressure by at least by 10 millimeter of mercury. For example, if the map is 65, our goal is around should be 75, because the data shows when you use these agents, then they have a favorable outcome, I would say. I'll say like if you look at it, there's nothing wrong with the kidney. The problem is in the in the liver, because the kidney, once the kidneys gets hypoperfused, when there's a drop in the pressure, in the filtration pressure, Here the reason is because more blood gets diverted to the GI area because of the splanchnic vasodilatation, and less blood goes to the kidney. So the problem is because of the shifting of the blood to the other area. Nothing wrong with the kidneys otherwise, because when when the kidneys were procured from these patients and transplanted to patients who were on dialysis, those kidneys were just fine. So we use vasopressor along with albumin for treatment of HRS-AKI, even though we have a lot of vasopressor available, but we don't use all of them. For the treatment HRS-AKI, we use terlipressin in combination with albumin. Um, because probably this has the best data out there. Terlipressin is used to increase the systemic vasoconstriction, whereas albumin improves the intravascular filling and reduces the extent of systemic arterial vasodilatation. So this improves the results of terlipressin basically. Now consider terlipressin along with albumin as the first line of treatment whenever terlipressin is available, and in the absence and if there is no contraindication, of course. uh, Now the data from Cochrane analysis in 2012 suggests improved survival in patients who received terlipressin along with albumin, even though no single study showed survival benefit in these patients. uh, Most other individual studies show that there is a trend in improved renal function when terlipressin and albumin were used in combination. As far as the dose of terlipressin is concerned, terlipressin given intravenously bolus 1 to 2 milligram every 4 to 6 hours, and albumin for first 2 days is given intravenously as an infusion 1 gram per kg per day, maximum 100 gram single dose, followed by 25 to 50 gram per day until terlipressin therapy is discontinued. If terlipressin is not available at your institute, can you use other type of vasopressor as an alternative? And when you look at the data, there was a small study by Dr. Duvox and his team, which looked at the looked at using norepinephrine along with the albumin, and the results from this study showed that 10 out of 12 patients had reversal of HRS when norepinephrine in combination with albumin was given to them. Therefore, norepinephrine along with albumin can be considered as a first line of treatment for ICU patient in type 1 HRS. Regarding the dose, there's no fixed dose of norepinephrine. You titrate the norepinephrine to increase the MAP by 10 millimeter. The dose is to titrate the dose to achieve 4-hour urine output more than 200 milliliter. Some other studies were also done which made the comparison between noradrenaline and terlipressin used in type 1 hepatorenal syndrome. Now, both of these studies by Dr. Sharma and Singh have shown that 50% response in norepinephrine group and 50% response in terlipressin group in the study done especially by Dr. Sharma and his team. Similarly, by Dr. Singh, norepinephrine group, 39% response in norepinephrine group and 43% response in terlipressin group, study done by Dr. Singh. Both of these studies were done in India. The conclusion from the results of these randomized trial is that they suggest that norepinephrine or noradrenaline is safe and effective as terlipressin, but of course is much less expensive than terlipressin. Therefore, you could choose either norepinephrine or terlipressin. How about using vasopressin instead of terlipressin? Because terlipressin is nothing but a longer version of the synthetic a longer synthetic version of the vasopressin. And structurally, vasopressin and terlipressin are similar. The half-life of vasopressin is only 6 minutes, whereas that half-life of terlipressin 6 hours. Looking at the from like similarity point of view. Vasopressin may be an alternative, but however, there is only a very limited data for vasopressin use in HRS patients. The typical vasopressin dose starts at 0.01 units per minute, and our goal is same to raise the MAP by 10 millimeter mercury from the baseline. Doses greater than 0.04 units per minute are potentially very risky and can lead to splanchnic, myocardial, and digital ischemia. Vasopressin is contraindicated in ischemic heart disease. Now, how about other agents like octreotide and midodrine in HRS-AKI? Both octreotide and midodrine also have limited data in their support, and most of the data is limited to retrospective comparisons. Now, data suggests that octreotide and midodrine are inferior to norepinephrine in managing the acute HRS. However, we may continue treating uh, these patients with octreotide and midodrine in non-ICU and non-hospitalized patients. Once the patient is transferred out of the ICU or out of the hospital, then these agents may be used to prevent the relapse of the hepatorenal syndrome. The typical octreotide dose is about 100 to 200 micrograms subcutaneously 3 times a day. And for midodrine, which is the alpha 1 agonist, the typical dose range is around excuse me 7.5 milligram to 15 milligram given by mouth 3 times a day. Well, so far, basically, we talked about the some pharmacological vasoconstrictor like the terlipressin, norepinephrine, vasopressin, midodrine, and briefly touched upon the octreotide. Um, Basically, the take-home points are the terlipressin and norepinephrine with albumin can be used in inpatient setting, whereas midodrine and octreotide can be used as an outpatient setting, for the HRS patient. Um, we already talked about the vasoconstrictor, but I didn't went into detail about the albumin. In my next lecture, I shall talk about the logic of using albumin and why does ascites form. Some diuretics like Lasix or furosemide and comparison between Lasix and spironolactone. In the meantime, stay healthy, do exercise regularly, stay away from alcohol, and thank you very much for watching. Thank you. Take care.